First, we are starting with Maitri Soni. She's a physiotherapist. She working with me, and she will start with presentation first.
Yes. Thank you, sir. Good evening, everyone. Okay, now we'll start the presentation. Today we are going to discuss two cases, and here we will start with one. The patient came to our clinic one day, and he was referred by a pediatrician. His name was Shrira. He was 12 years old. His parents were complaining about that arch is not visible. Those were the words of his parents. And then I start with the case detailing because the sir was busy with the other patient. So I take the complaints that he was not having any symptoms, that he was not having any pain. He was a functional kid, and he was good in all ADL activities. Then reach to any conclusion, I like to think about it that there is always a debate about Flatfoot, that pediatric Flatfoot specific, to treat it or not to. And there are also some consensus about it, that if it's rigid, then you treat it, and if it's flexible, then leave it, don't treat that. So forward, I think that my anatomy and biomechanics, I should go with the basics first. Then I clear up the thing first, and I would like to share it with you. Here you can see the arches. We have 3 arches on our foot: medial, longitudinal, lateral longitudinal, and transverse one. The weight distribution in our foot is like 50% goes in the backward, in the hind foot part. As you can see in the medial arch, that is calcaneum, talus, and navicular. And in lateral, it goes on calcaneum and cuboid. That is the hind foot part of the area. And the other weight distributes in the forefoot part, that is covered by the sesamoid bones at the first metatarsal base and the other 4 metatarsal heads. The transverse arch covers 3 cuneiforms, bases of the metatarsal heads, and cuboid. Now we'll go in detail for the structures around this bone and how the mechanism of the arches are working. So let's assume that our arch is like a bridge. Now you can see the bridge is the structure who holds the shape, and if the weight comes on it, it still maintains the shape. It doesn't break down. So in our body, it is like same. The first thing is keystone is the bone that is having a the big structure, and the staple thing is that the little stones, and it's like a cement structure who holds the big bones together. It's like our ligaments and small muscles and the small bones. Then we come to the tie beam part, that is the base of our the bridge that holds the pillars of the bridge. And in our body, that is the muscle tendons. And then comes the suspension part. It is like a cable part who holds the bridge from above, and it maintains the structure throughout. This is the detail in the bridge structure. I'm going to explain about it. Medial arch, in medial, lateral, and in transverse, the talus, and then cuboid, and in transverse, there is cuneiform and the basis of the metatarsal. These are the keystones that I explained in the bridge structure. And now we are going to see the medial arch. In medial arch, there is the calcaneonavicular ligament and tibialis posterior. That comes in the structure, the small part of that structure that holds the big bones. And then the tie beam of the medial arch, that is plantar aponeurosis, and the flexor part of the medial part of the flexor muscles that covers the medial area, which is flexor hallucis brevis and flexor and abductor hallucis longus. And the suspension, the cable in the medial arch, that is tibialis anterior. Now in lateral part, the tie beam and the suspension, it works like the laterally the peroneus longus and brevis comes and holds it, so the structure of the lateral arch maintains the shape of it. And same as in a transverse arch, the peroneus longus tendon goes in below the transverse arch and maintains the tie beam and the suspension both together. So this was the summary of the little detail of the arches, and now we are going to see the mechanism of the flatfoot. As you see that you are sitting on a chair and the four legs of the chair are steady. So your posture of the body is steady because of the chair. And if suppose that one leg of the chair is not steady or it's broken, so what happens to your body? Your body leans down and it gives you a dysfunction. So as in our foot, the foot are our pillars of the body and it maintains the building-like structure and it helps us to give a steady posture. So the alignment of the foot is really important to maintain our chain, our body chain. So the alignment foot is equal to the alignment body, and if it's misaligned, then the body is to misaligned structure. Here you can see if the medially and pronated flat the feet are, so the tibial torsion and then the femoral anteversion that leads to your tilt in the hip and also spine dysfunction. The chain adores is because of the feet. So feet are really the foundation of our body that should be treated first and look after first as a physio, because muscles and the structures of the body is really important for us. Okay. Now the assessment part, as I come to the assessment part, I took help of Dr. Kaushathar and I would like to give my.
Okay, so when she asked me what is the etiology, how it happens, and it is always the question why flatfoot happens in pediatric patients or pediatric kids. So generalized ligament laxity is very common in child. Second thing, 25% of child might be having gastrocnemius and soleus tightness. So go to next slide please. What could be the symptoms? When parents comes to us, what could be the symptoms we can see in our child? Outward tilt at the heel, outgoing. Second thing, change the gait or awkwardness when walking. When patient, what she talked, when they came to us, there was no complaint at all. Difficulty moving foot from side to side or up down, feeling pain and tenderness anywhere from foot to knee, pain or difficulty when wearing shoes and withdrawing from physical activities. So these are the complaints usually parents tell to us. Then what could be the classification of pediatric flatfoot? Hypermobile flexible splenovalgus is the most common. Usually it runs through family. So when we are having child, we always see the parents, foot of the parents also associated with generalized ligament laxity, as I told you, and lower extremity rotational problem, tibial torsion or femoral anteversion. Usually it is bilateral, associated with accessory navicular, which is not treated by us. Flexible splenovalgus with tight heel cord, we are going to treat tight heel cord, and rigid flat foot and tarsal coalition, we are not going to treat it. That is up to pediatric orthopedic surgeon. Now, what could be the differential diagnosis? Tarsal coalition, most commonly calcaneonavicular or talocalcaneal coalition with both the bones fused together. Congenital vertical talus, a rare congenital condition caused by neuromuscular or chromosomal abnormalities. We have one patient of congenital vertical talus operated by pediatric orthopedic surgeon. When they came to us, this condition looks like it is a medial arch collapse, and this patient having operated for the spine, Tether cord. Okay, so now we are understanding that why this patient was having something else also, an accessory navicular. Now we go to the assessment part. How as a physio we can assess? One is the foot posture index. It is 6, -6 to +6 for children aged 3 to 15 years. Stanley Arch Index is very easy to check. It is 1.07 for children aged 3 to 6 and equal or more than 1.28 for children 6 to 9. And Chipmuk's Spinal Index is more than 62.7% in 3 to 7 years old, and in more than 59% 6 to 9 years old, and more than 40% for children aged 9 to 16 years. So let's go to the Stanley Arch Index. Support width is of the central region is A and support width at the heel region is B. So please go to the So A divided by B into 100% is going your is Stanley Arch Index. Go to next slide. But this is a more easy way to assess. This is heel raise test. When we are asking patient to do the heel raise, and if arch appears, this is flexible flat foot. If arch doesn't appear, this is rigid flat foot. There is other test also is there, great toe extension. Just make patient to stand, do the great toe extension. If arch appears, that is a flexible, and if arch doesn't appear, that is a rigid flat foot. Flat foot deformity in children can easily visually evaluated by, usually you can see from all the sides. You have to see from the dorsum, you have to see from the posterior side, you have to see from the medial side also. Furthermore, palpation of subtalar joint axis, either in the sitting position, either in the supine position, or either in the standing position. Go to next slide. Yeah. So as you are seeing here, subtalar joint axis usually pass from the first metatarsal row, from here talus to first metatarsal row. Okay. When it is medially deviated, you can see here this is a medially deviated. So you can see here this is a normal subtalar joint axis, and here this is slightly medially deviated. So when this is the very easy assessment. Actually, because of time constraint, I cannot show you proper way practically, but this is a very easy. Just put it a mark, and we can see how much axis. Why this is important as a physiotherapist? Because so many times patients ask us whether they need arch or not. So when we are saying how much, I made a Flatfoot foot plate for this. So if we are getting this patient, we just do some correction with foot plate. Next slide. What age arch develop? Because all the patients, all the kids, those who have seen their kids grown having a flat foot. This is a pathological? No, this is a physiological, because they are having subcutaneous fat in the foot. This is normal, and at the age of 6, usually child's feet are flat. After that, arch started developing. Okay. Now, when I was searching for references, I got this algorithm. What this algorithm says? Pediatric flatfoot patient comes to us. We have to see first either this is flexible or rigid. When this is rigid, refer to pediatric orthopedic surgeon. We don't have to do anything. But when there is a flexible, just ask, there is a pain or no pain. If there is pain, treat it. Either you have to give footwear, either you have to give foot orthosis, or any other method, any physiotherapy treatment. If there is no pain, child is less than 8 to 10 years, just consider ligament laxity, just consider BMI, because child weight might be more, and if function is not okay, go for differential diagnosis with neurological symptoms and treat that. If child is more than 8 to 10 years and they are having problem, just treat that with physiotherapy or with orthopedic opinion. When they are having no problem at all, just general advice, footwear and BMI. Treatment for flat feet targets. What is the physiotherapist, our role would be arch activation and strength, lower extremity strength and alignment, efficient fluid and motor pattern, biomechanics of gait. When she talked about biomechanics, she showed this very beautiful picture of bridge. Okay, until and unless we know which muscles to be worked on, usually I had in my mind that whenever patient comes to us with flexible flat foot, just treat with intrinsic muscle of foot, nothing else. Okay, but when we are seeing the structure, that what is a suspension? This tibialis anterior, it is tibialis posterior, so that muscles also we have to treat instead of just treating the intrinsic muscle of foot. Okay, so as a physiotherapist, when we know the structure, how it is, arch is holding, which muscle is holding, that's what we are going to treat as a physiotherapist. Can anyone tell me what is this? Most senior people might be knowing. What is this treatment called? Paediatric football. That's what I know, because in the older time this was very popular method, but nowadays this method is not much used. This is a Paediatric foot bath, and when I was seeing the literature, I got a good review about the Paediatric foot bath also. This is usually we are not using in our clinic also, but we are having stimulator. And what Paediatric foot bath effect on flexible flat foot says, okay, a statistical analysis, a significant improvement was found in the Stanley Arch Index. A level of improvement is more than 0.001, was significant high with Paediatric foot bath with flexible flat foot. Okay, so study concluded that 3 weeks of Paediatric foot bath can good in the managing flexible flat foot. Next slide. This is a few exercise. We have showing what are the things, there's some ideas we have put. Not only these things we can do, there are so many other things also can be tried. This is a simple intrinsic plantar muscle arch activation, gentle foot massage. You can use sensory ball with vibrator or textile input. Scarf lift, just lifting a scarf. Then toe basketball, just take a small balls and take from one to other side. Then single line balance. This is a soft cushion pillow what we are having in our clinic. Half knee ball toss. Then lower extremity strength and alignment, disc balance. This also we have in our clinic. Okay, maintaining balance. This is a very good for foot activation. We are using for almost all neurological patients. We are using this both the things. But he is my son. He is always model for my all the presentations. Half moon balance. This is a half bolster. Okay, from roller we are to see the foot activation. You can able to see the tibialis anterior is working here. Okay, when he was not, see here tibialis anterior is not working as a dorsiflexor. Here tibialis anterior is highly working when he is just taking up. Okay, so this is what I was activating. See the tandem stance. Here also I wanted to activate foot muscles as well as tibialis anterior also. Tactile footprint. Just put a footprint and make the child to walk. Those who have seen our Hildreth clinic, we are having footprints. We are just making child to walk on that. Scooter adventure, make them to sit on small scooter and do the arch marching. Then again tactile footprint for motor planning also. Jump down from the small platform. Jump onto platform, promoting the full foot contact and increase the height of platform as child gain the mastery. Biomechanics of gait, again sitting on the ball, which is dynamic surface, and down we are putting the soft cushion. So biomechanics of the gait, where we need a good dorsiflexion, knee flexion, knee extension, everything we can achieve. Next slide. Wrist kick, standing on the soft cushion and putting anything in front of you and just kicking can also help you in the foot muscles activation. Bear walking, have a child to walk across one place to other place. So you are just lengthening the heel cord, you are lengthening the hamstrings. You can go for the penguin walk, walk on the heel. So this is one case. Okay, this case also we got. He is age 4.6. So what should I suspect? This was referred to me by pediatrician, and this hand, like this is a flat foot. What other things should I consider here? He is a male, number 1. Number 2, age, 4.6. So what should I consider as an age part? Till 6 years we can wait, because we can suspect there is always physiological flat foot in child. Yes. That next slide please. This is the Staheli arch index, and left side it was 1.23 and right side it is 1.24. So it is normal at the age wise. And this is a heel raise test. We ask him to heel raise, and you are able to see here arch appears. So this is a flexible flat foot. This is the case 2. Okay, for this patient we have started searching all these things. Okay, and he was at 12 years old. So what should we do? Let's go. Here 2 videos are there. See, are you able to see? There is no arch appears. This is a rigid flat foot. And sorry. See, grade 2 extension test. Arch is not appearing. So both the tests are negative. This is the calcaneum. From tender Achilles we put one straight line, and it is laterally deviated. Okay, and I have made a foot plate. I have just corrected it. See this line. Okay, so as a physiotherapist, good foot alignment is important for me. As she said, as a physiotherapist, when we are having patients, we always see their foot, because that is a base. When base is not good, always we are seeing postural malalignment in our body. So that's why I just corrected his base. I taught him some exercise. I told him to wait, come for the follow-up after 1.5 months. So what could be the research or evidence says? Okay, he is there, Baldev Bhai, and he is an orthotic person who came from all over from Ahmedabad, and he always asks why you are not sending patient to me when you are dealing with a foot plate. Okay, foot arch they are making. Okay, what about the orthosis? Should we refer for an orthotic person? What this study says, revealed that flexible flat foot in young children slowly improve with growth regardless of type of footwear they use. But however, this systemic review suggests that 3 out of 4 case series study revealed that positive long-term effect could be achieved using orthosis. So yes, orthosis can be prescribed. Now when patient comes to us, any patients, usually we are seeing only child, okay, but our normal relatives child also comes to us, and they are asking which footwear should be advised. And this is very important part. Why? Because when child is small, don't allow them to wear closed toe or open toe footwear like slippers or shoes. No. What is good? Sandals. Okay? But when they are toddler, but when they grown up, always ask them to go bare walk. Slippers can be advised up to 6 years. Okay, why so many flat foot? Because now how many of us can walk barefoot outside? I cannot. Because my sensitivity is too much. I have not used when I was young. Okay, so when they are toddler, any child, I am not talking about only flat foot, when any child, any relative child or our child, this is a good research I got. Okay, for our patients or patients relative, when they are asking, best, don't go for open toe or closed toe, sandals are best. After 6, tell them to slippers or anything is fine, because after that they are going to school, they are going to wear shoes. Okay, so next slide. Case 3. Anything are you able to see? Flat feet, right? Next slide. And there she is. Okay, come. She is a patient of flexible Flatfoot. She is having back pain. She is having neck pain because of wrong posture. So if it is not, come here. We go for the heel raise and see arch appears. But if this is not treated in the childhood age, at this age, we are not going to ask her age, but whatever age it is, this age, because of wrong biomechanics, she was having back pain, neck pain. So I, as a physiotherapist, put my point, either this is flexible or rigid. Rigid, definitely we are going to treat, but here I am not talking about orthosis, not talking about arch, but as the muscles, we are going to treat it, strengthen it, tight heel cord, stretch it, or good positioning. So good biomechanics, good base, good posture, no pain in the adulthood. That's what my message as a physiotherapist. Thank you. Now I hand over my presentation to Dr. Chandra, and we are going to have so many arguments because CL also prepared.
So it's a nice presentation. So first of all, thank you, Dekani sir and Dr. Kaushal Bhatt and you all your guys for giving this opportunity to share or discuss this interaction. I think su sacho ke hu sacho ne kata better say ke su sacho. That is what. So let's see. He has also so many evidences and I also some evidences. Let's see. We'll go one by one. મારો અવાજ તમને બરાબર સંભળાય છે ને તો આને મૂકી દઉં છું. So this is a 2-year child. Parents comes to us. કે સાહેબ શું કરું? ડિફોર્મિટી છે અને તો શું કરું? તમારી પાસે પણ આવા સેમ ક્વેશ્ચન લેમ કે કૌશલ પાસે આ તમારે. So there are multiple options. A therapy, શું modifications, C છે medial arch, surgery option. શેમાં જશો? Observe. Are you ready for that? Everybody? Fine. Let's discuss another case. This is case 2. 10-year female, child having a deformity. Both fit deformity. 10 વર્ષની female child. No pain. Pain nothing. So again there is a file. Wait. A, B, C, D, E, F. શેમાં જશો?
Surgery.
You go for surgery. B. Shoe modification. A, B. As a therapist, definitely you go for therapy. As a surgeon, I will definitely directly will not go for surgery, but I will think about. So this is for, all are you going for? A. કેટલા લોકો A માં ready છે? Okay, fine.
Without assessment.
I'm not about C. I know C. Definitely, we'll go for assessment, but it's just a quick question. I know we all are intelligent. Definitely, we'll go for it. First, we'll inspect everything, then we'll go. This is a case 3. 12-year male child, difficulty in walking. Now the complaint is different. Okay, there is a difficulty in walking. There is very bad deformity. Again, A, B, C, D, E. Where will go? Kaushal. I know that.
दोनों टेस्ट करेंगे.
Okay. नहीं वो मुझे पता है. Assessment किए कि ना आप.
Rigid और flexible. If it is rigid.
Yes. लेकिन अभी भी बहुत difficulty है आप. One liner. I want one liner answer. We'll go for that. इसमें कहाँ पे जाएंगे? Therapy. We'll go for surgery. Okay, fine. I'm so happy you will refer. आप मुझे refer कर देंगे. Again, there is a case 4. 10-year female child. Again, there is a walking difficulty. Both fit deformity. Same. I think we'll go for a assessment. Because I want to highlight the every case is in. Yeah, this is a 15-year child. Deformity of both fit. Pain after long walking. Again, the presentation is different. Now, where will you go?
A and B.
You will go for therapy, you will go for soul modification. Yeah. Kaushal A, B કે છે આપણે શું કરીશું?
Both A and B.
A, B. The last one. 10-year male child, fit deformity, but it's progressive. પેલા સાહેબ બિલકુલ ઓછું હતું, જેમ હાઈટ વધી એમ વધતું ગયું, and the things pain while walking. So again presentation is different. Where you will go?
A, B, C.
A, B, C, D. Okay, fine. So it's a good thing. Now, so let's say it's very common deformity. હું મારી ઓપીડીમાં ડોક્ટર જયમીન હેઝ જોઈન્ડ મી એઝ અ એસોસિએટ ઓર્થોપેડિક સર્જન. અને મને પહેલી વાર જોઈને મને કે આટલી બધું પ્લેટ પીટ છે કાલે. ઇટ્સ વેરી કોમન. આજે મહિનામાં એપ્રોક્સિમેટલી કૌશલ ફ્લેક્સિબલ ને બધા ભેગા થઈને ઓલમોસ્ટ 25 to 30 patients we are regularly seeing. It's a very common deformity. The reason is, you know, flatfoot તો પહેલા હતા જ. હવે we are using internet. પેરેન્ટ્સ ની બધાને સિંગલ ચાઇલ્ડ થઈ ગયું. They are very so aware કે ઓ આ તો ફ્લેટફૂટ છે. જેમ કીધું કે 10 વર્ષ સુધી કોઈને વેઇટ કરવી નથી. તમારી ને મારી બંનેની ઓપીડી છે ડે બાય ડે અવેરનેસ જેમ વધશે એમ ફ્લેટફૂટની ઓપીડી વધારે. Yes,
Diapers are a major.
I'm coming this point. Diaper, there are multiple issues because hyper, walker induced. Walker વિશે આપણે ચર્ચા કરીએ પાછા. I don't like walker. હું છે ને ભાવનગરનો જમાઈ છું. એટલે અમારી ત્યાં બે દીકરા આયા. એટલે બે વોકર આયા. વાત કરું છું આઈ થિંક. હા, 12 વર્ષ પહેલાની વાત છે. વોકર લઈને માળીએ ચડાવી દીધા પહેલા. ના તો ન પડી શકું કારણ કે ભાવનગરને બહુ જાજુ ના કહેવાય જ નહીં. So brief anatomy already you have observed that directly. So why, you know, have you seen all 6 cases? And તમે પણ have you observed that you could not tell that it requires physiotherapy or patients required only shoe modifications, patient requires surgery. That's why it's a multidisciplinary approach. It is not a one kind job. It is not a therapist job. It is not a prosthetist job, or it is not a surgeon's job. We have to sit together. We have to identify the etiology, assessment, and then treatment should be planned. Same as like cerebral palsy. CP, what we do it's a multidisciplinary approach. It is not a single job. हमारी सर्जरी में એવું કહેવાય કે સર્જરીમાં બધું જ જોઈએ. ખાલી આર્ટરીથી સર્જરી ના થાય. ખાલી એક સિંગલ આર્ટરીથી બધું મથી ઇટ ઇઝ નોટ પોસિબલ. લાઈક થેરાપિસ્ટ ઓલ્સો યુ નીડ મલ્ટિપલ ઇક્વિપમેન્ટ્સ. આપણે ખાલી એક મસલ સ્ટ્રેન્થનિંગ અને સ્ટ્રેચિંગથી ફિઝિયોથેરાપી ન થાય એવું હું સમજ્યો છું. એના અંદર મલ્ટિપલ ઇક્વિપમેન્ટ્સ are there. So as a flatfoot, if you want to treat, you need a multidisciplinary approach. So how? Let's see. So this thing is very important. Have you observed that કે ભાઈ arch flatfoot why we should treat? Why? શા માટે ટ્રીટ કરવું જોઈએ? આપણા મનમાં એવું છે કે ભાઈ આ આર્ચ આવે એના માટે. It is not like that. The main objective है ना to limit the progress of the deformity. There are so many flatfoot. તમે જોયા તમારા પેરેન્ટ્સ હતી મે આઈ થિંક નામ શું મૈત્રીને પણ ફ્લેટ સ્ટીલ હેવિંગ અ ફ્લેટફૂટ. બરોબર? કેટલા લોકો એવા છે જેને ફ્લેટફૂટ છે ને કોઈ જ પ્રોબ્લેમ નથી. The thing is we have to understand what is our objective. The thing is limit the progression of deformity and એનાથી થતી કોમ્પ્લિકેશન ને બચાવી. That is our aim and objective. What are the most common cause? એમાં આપણે નથી જતા. We go fast. ન ટ્રીટ કરીએ તો ફૂટ આવો દેખાય. Again we are going to discuss. See, this is very important. Already Kaushal has identified, but I want to highlight this. How we will assess this. Arch will develop. This is a flexible flatfoot. Once again, will rise, or if you go for a just non-weight bearing, you will see the arch. That is a flexible flatfoot. There is no need to treat if the flexible flat foot is asymptomatic. Why? I am telling this one now. So this is very important. Again, we will come to case 1. Fine. So 2-year child, pelo case to age case again. How he walks. This is a walking video. How he walks. આવી રીતે ચાલે છે. પેરેન્ટ્સે કમ્પ્લેન કરી કે આમ ચાલે શું કરું? So you already rightly said કે આને શું કહેવાય? કૌશલે કીધું this is a very common deformity. This is called pseudo flatfoot. શા માટે હોય? Medial arch ઉપર એક ફેટનું લેયર હોય. તમને looks like flatfoot but it is not a true flatfoot. Just wait and watch. જેવો જેવો સમય જશે ને એ જતું જ રહેશે. This is very important study. Feet is growing organ. Kaushal 6 years kida. I will tell up to 10 years. more than 10 years પછી we have to think about up to 10 years it's a growing thing. બહુ મસ્ત સ્ટડી છે. મોરલે એને 835 ચિલ્ડ્રન્સ લીધા ફ્લેટફૂટ વાળા. એ લોકોને 97% ચિલ્ડ્રન હેવિંગ એ ફ્લેટફૂટ એટ ધ એજ ઓફ 18 months. 18 મહિના સુધી કોને હતા? બધાને ફ્લેટફૂટ હતા. એવા જ ફ્લેટફૂટ. સેમ ચિલ્ડ્રન they have assessed. એના ચિલ્ડ્રન 54 થઈ ગયા 3 વર્ષે, 26 થઈ ગયા 6 years અને only 4% at the 10 years. તો એવું જોવામાં આવે કે ફ્લેટફૂટ તો ખરેખર ડિસઓર્ડર્સ જ નથી. વિધિન 10 years it will kill them. અને બાકીના જે 3-4% જે વધ્યા છે ને એ પણ છે ને એમાંથી સિમ્પ્ટમેટિક હોય એવા તો ખાલી 10% જ છે. કારણ કે બાકી there is a shape of foot. There is no need to treat. So after 10 years we have to think about it. So case 1 doesn't require any treatment. This doesn't require any treatment. It will go its own. Now this case, okay, we'll give little bit hint. Yes, this case is having a hyperlaxity of ball joint. Same case, this one, 10-year female child, both fit deformity, no pain. એમને પેઇન નથી, પણ એને શું છે? હાઇપરલેક્સિટી બધા જોઈન્ટ છે. This is most important test. આ ચેક કરો ને તમે, ઇટ્સ વેરી કોમન ટેસ્ટ. આ જો અહીંયા ટચ થઈ જાય તો this is hyperlaxity. તો લોકોને ફ્લેટફૂટ હોવાનું, કારણ કે એનો સ્પ્રિંગ લિગામેન્ટ છે, જે મૈત્રી વાત કરી કે નીચેનું જે મેઇન કેબલ છે એ લૂઝ છે, તો ફ્લેટ જ હોવાનું. સો what you will suggest for this patient? Okay, there are very common prescription. Now there is a lot of discussions. આ પેશન્ટને આપણે જોઈએ, there are two prescriptions. આ હોવાની. A, diagnosis of flat feet. If I am an orthopedic surgeon, Jaimin is a co-surgeon. If I want to ask him, he will go for a X-ray. X-ray normal છે, do physiotherapy, do medial arch support and shoe modification. That is a prescription 1. Prescription 2 will not cause problem, investigation not required, no treatment is required. So there are A and B. Now, who is agree with A and who is agree with B? I would ask. I will ask Kaushal last one. A માં કોણ જશે ને B માં કોણ જશે? There are two prescriptions. Again, I will back to this case. So this is a case 2, 10-year female child, very bad deformity of foot, no pain, hyperlaxity of joint, and this is 2 prescription. B. If you tell B, then I will ask why. This is very important debate because Kaushal is ready to fight with me for A also. I know that because you are therapist. I am telling about therapist don't require therapy. Then you will be thrown me.
It's asymptomatic, na? And it will cure it on its own.
But it's after 10 years. Yeah, that's true. But because I want to show something, that's why that's good. That is B. How many are agree with B? Thoroughly, huh? B. Okay, fine. And how many are agree with A? Okay, fine. So that's now we'll discuss. Definitely you will go for a A. And now both it's a discussion. Who is right? It's not like that. So A is X-ray is normal. We'll forget X-ray. उसका normally आता है. उसका X-ray कभी कराना ही नहीं है. And orthopedic loves to do X-ray. That's how I know. Yeah, it's very common. મારી પાસે પેશન્ટ ના ના ઇટ ઇઝ વેરી કોમન. પણ અમે હજી સુધી અમારે ફ્લેટ ફૂટના એક પેશન્ટ એક્સરે પર there is no need. નથી. શા માટે નથી જરૂર પડતી બતાવો. See, the role of muscles in maintaining arch. હમણાં જ એને સરસ મજાની એનાટોમી બતાવી. See, it's a completely dependent on talocalcaneonavicular ligament, the spring ligament. It's a ligament. It is not muscle. મસલ છે ને ટેન્ડિનસ પર એક જ મસલ છે. હા, ઇન્ટ્રિન્સિક મસલ્સ છે એ કામ કરે છે. બટ there are studies on EMG નો સ્ટડી થયો. It's a very good study. There are no muscle action while standing. ફૂટ માટે ફૂટનો આર્ચ મેન્ટેન કરવા માટે મસલ, હા, when you are putting heavy load then muscle is low. ત્યારે મસલનું કામ છે. That's why આ પેશન્ટમાં after 10, હા, Kaushal will tell you if you align the foot then it will help. But after will tell that alignment is definitely important, but it will not create your arch. That is very important. Second thing, if you will go for a shoe modification, shoe modification, I think Badadev beto છે. So there are 200 school going children. In our study here, there are 2 groups. The children walking with modification and without modification. So those walking without shoes having a better arch than those walking with shoes. અમારો સ્ટડી નથી, એ લોકોએ 2300 નો સ્ટડી. ચાઇલ્ડ વોક્સ બેરફૂટ, જે હમણાં જ વાત કરી ગયું છે, જે લોકો બેરફૂટ વોકિંગ કરે છે ને, there are high chance or better chance to develop arch. When I went to Cincinnati, there was a study, એ લોકોએ સ્ટડી કર્યો 50,000 Flatfoot. આ તો જે લોકોને Flatfoot એનરોલ કરાવો, પેલા આપણે પણ જ્યારે when I started my orthopedics, અમે મીડિયલ આર્ચ લખતા જ બધાને, અને બધાને શું મોડિફિકેશન કરાવતા. તો એ લોકો ખરેખર કામ કરે છે કે નહીં? તો 50,000 કેસનો સ્ટડી એ લોકોએ 10 વર્ષ સુધી કર્યો. આપણે તો શું કહેવાય, when they tell, કે હું કહું કે કૌશલ કે somebody will, દોડિયા કોઈ આવીને કે આ કરવું આપણે, we will start. It's very common for us. તો એ લોકોએ સર્ચ કર્યું, they have કે ભાઈ એ આર્ચ કે શું મોડિફિકેશન આપ્યા ને, એ 50,000 માંથી કોઈ ફરક નથી. એ જે ફરક પડવાનો હતો ને, that is natural in flexible Flatfoot, not in rigid Flatfoot or some other causes. Medial arch support again. કેટલા લોકો તમે મિડલ આર્ચ ઘણા બધા આપતા હશો? હાઉ મેની આર યુ ગિવ મિડલ આર્ચ ઓનેસ્ટલી? હિલ રેઝ માટે, અલાઇનમેન્ટ માટે, આઈ નો ધેટ, અલાઇનમેન્ટ માટે. બટ whenever there is a theme that limits the normal function of extrinsic and intrinsic muscle, અહીંયા હું કૌશલને ડેફિનેટલી બેટ કરીશ કે સી મેં તારી 10 we have seen 10 physiotherapy, tactile stimulation, heel rise. You are going a stimulation or you are strengthening for intrinsic muscle, and age intrinsic muscle ને તમે rigid mold માં મૂકો. If you are going for a physiotherapy and reverse, we are putting a rigid mold. એવું એકેય જે મોલ્ડ નથી, શું આ એ rigid mold જોવાનું, that gives a weakness of intrinsic muscle. આપે કે ન આપે, that leads a weakness, that gives a problem. So that's a medial arch in a flexible way, it is not indicated.
Second, it causes keloid formation.
See,
Because you bear weight on that, that skin becomes harder.
hard. અને સાહેબ હજી કહું કે જે લોકો મિડલ આર્ચ પહેરતા હશે ને, એમાંથી 90% બચ્ચાને એક ડિસ્કમ્ફર્ટ હશે. ઇટ્સ વેરી કોમન. અને આટલા રિજિડ ફૂટમાં તમે આર્ચ આપો ને, ઇટ ઇઝ વેરી ડિફિકલ્ટ. શ્રુતિ મૈત્રીને કહે છે ને, તો મિડલ આર્ચ સપોર્ટ પહેર, હું ગેરંટીથી કહું છું 3 મહિનામાં કાઢી નાખશે. ઇટ ઇઝ વેરી ડિફિકલ્ટ ટુ વેર, બહુ ડિફિકલ્ટ છે. યસ. તો બીજો પ્રોબ્લેમ છે કે will not cause problem. મેં બી પ્રિસ્ક્રિપ્શનમાં રાખ્યું હતું, will not cause problem, investigation નથી required, no treatment is required. See, 3,600 Canadian army recruits હતા. આપણે આર્મી ફ્લેટફૂટ હોય તો આર્મીમાં નથી મળતું. હા, that is very Canadian study. Flatfoot doesn't cause disability. આવું લઈને બેઠા છે, કશી ડિસેબિલિટી છે જ નહીં. There are no disability for Flatfoot. એટલે it will not cause a problem. હા, આર્મીમાં ન જઈ શકે, ઇટ ઇઝ નોટ એ ડિસેબિલિટી. will not cause a problem. Another 2300 children adults with Flatfoot. Benjamin Joseph એટલે I met, he is a pediatric orthopedic guru, very artisanal practitioner of Manipal. He studied, he is very against about any shoe modification in Flatfoot. There are multiple reasons. એને પોતાના 2300 ચિલ્ડ્રનનો સ્ટડી કર્યો, લખ્યું કે જનરલી they are asymptomatic, એને કશું આપવાની જરૂર નથી. નો ટ્રીટમેન્ટ ઇઝ રિક્વાયર્ડ. છેલ્લું બી માં હતું, બરાબર? પોપ્યુલર ટ્રીટમેન્ટ કઈ છે? આર્ચ, એક્સરસાઇઝ, સિલિકોન જેલ, મલ્ટિપલ થિંગ્સ. ઘણી બધી પેશન્ટ તો મારી પાસે થેલી ભરીને આવે છે, આટલા શૂઝ બનાવ્યા પણ મજા જ નથી આવતી. ફૂલ થેલી, હો, સિલિકોન જેલ. આ લોકો જેટલી બનાવી આપે ને, એટલે ઓનલાઈન મળે છે સિલિકોન પેડ, મલ્ટિપલ થિંગ્સ. પેશન્ટ એક જ બાજુમાં બચ્ચું બેઠું હોય ને, અંકલ અમને જરાય નહીં ભાવતા. ધીસ ઇઝ ટ્રુ સ્ટોરી. હો, નથિંગ. એક જ અંકલ જરાય એકે ગમતા નથી, અને હું બધા કઢાઈ નાખું ને, એટલું મને પ્રેમ કરે નહીં બાળક. There was a prospective study, 3 years, Texas Scottish Rite study છે. કંટ્રોલ ગ્રુપ કે જે લોકોને એમને રાખ્યા ને, કરેક્ટિવ શૂઝ, આર્ચ સપોર્ટ, યુએસબી, આટલા લોકોનો સર્વે કર્યો. they control and treatment group, there are similar results. આપ્યું યુએસબી, કઈ ફરક નહીં પડ્યો. ટ્રીટમેન્ટ does not produce better results. અને આખા આર્ટિકલ છે, મેં તો ખાલી એબ્સ્ટ્રેક્ટ લખ્યું છે, નથિંગ. અમારું કોઈ જ સ્ટડી નથી. there are already બહારનો સ્ટડી. correction occurs naturally, treatment can't change the foot shape. even though આપણી જે પ્રોસ્થેસિસ બેઠા છે ને, તોય આપણે બોલી શકીએ. it is very good. it doesn't, હા, it is required when this is important. એ ક્યાં શીખીએ આપણે? so last one કે ભાઈ પેશન્ટને ઘણીવાર એવું થાય કે સાહેબ આપણે કાંઈ નથી કરતા તો કાંઈક તો લખી આપીએ, આવું કહીએ ને. એટલે અમે ઓર્થોપેડિક કે કાંઈક કસરત કરો, કે કાંઈક શૂઝ પહેરો. ધીસ ઇઝ વેરી કોમન કે ભાઈ ચલો ને પેશન્ટને રીએશ્યોર કરીએ આવું થાય કે નહીં મનમાં? સી એકવાર કેસ કઢાઈ લ્યો, તમે 400 રૂપિયા લઈ લીધા છે, મેં 2200 રૂપિયા લઈ લીધા છે, એ નહીં, એમ તો નહીં કહેવાય કઈ કરવાની જરૂર નથી. ઇટ્સ વેરી નેચરલ ને, એને કંઈક તો આપણે ના, પણ એમાંય છે ટ્રીટમેન્ટ મે નોટ બી ઇફેક્ટિવ બટ ઇટ રીએશ્યોર્સ ફેમિલી એન્ડ ઇટ ઇઝ નોટ હાર્મફુલ. ના, એવું નથી. તો અગેન દે હેવ સ્ટડી આટલા વસ્તુમાં એને કોઈ સ્ટેહેલે એ લોકો સ્ટડી કર્યો, જેપીઓનો આર્ટિકલ છે, અમારો બેસ્ટ પીડિયાટ્રિક ઓર્થોપેડિક જર્નલ. એમાં જે બચ્ચાને જરૂર નથી ને એ બચ્ચાને તમે શું મોડિફિકેશન આપ્યું છે, ઇફ યુ ગિવન એ મિડલ આર્ટ સપોર્ટ, કે જે આપ્યું છે ને, દે આર સફરિંગ ફ્રોમ ઇન્ફિરિયોરિટી કોમ્પ્લેક્સ. એ બચ્ચાનું બાળક હોય ને, જે 30 જણાનો ક્લાસ હોય, એમાં 2 જણાને આર્ચ હોય ને, તો 2 જણાને દે આર સફરિંગ કે મારા ફૂટમાં કંઈક પ્રોબ્લેમ છે. ઇટ ઇઝ કોમન નાઉ. તમે જોયું, આપણને હેડેક થતો ને, મને હેડેક થયો ને, એ તો મને સેકન્ડ MBBS કે થર્ડ MBBS માં ખબર પડી. આઈ થિંક આપ તમે બધા એગ્રી હશો. જ્યારે અત્યારનું બચ્ચું 5મા ધોરણનું બચ્ચું મને એમ કહે છે, અંકલ આઈ ફીલ ડિપ્રેસ્ડ, આઈ ફીલ બોર્ડ. આ બોર્ડ શબ્દ મને હમણાં ખબર પડી. આર યુ એગ્રી વિથ ધેટ કે નહીં? ઇટ ઇઝ વેરી કોમન. સી દે હાવ સફરિંગ. એ લોકો જોવે છે કે એ બચ્ચા શું પહેર્યું. સો આઈ એમ સફરિંગ એનીથિંગ even though it is not a disability. So it gives a lot of inferiority complex, cost and discomfort to check. So particularly these days, I know that is a flexible flat fit. Yes, there is a malalignment. Malalignment is there. So no investigative treatment are not effective, but it has a side effect. છે આ બધું આને middle arch support આપી, it will not give. Yes, definitely you can supportive treatment, like you to strengthen the intrinsic muscle, strengthening, or you give us some sports wear, sports shoes, shoe modification, that will help. That will reassure it is not a part of treatment. Fine. This is case 3. Difficulty in walking, deformity of both feet. This part, so it is a known case of cerebral palsy. Definitely we have a cause now. Whenever there is such foot deformity, the cause is cerebral palsy, TA is so significantly tight, mid-foot break is there, foot is pronated, there is a heel valgus, there is a crouch gait, there is a sparsiality. That foot require comprehensive approach. ખાલી physiotherapist થી પણ ન થાય. મારો હું ખાલી as a pediatric orthopedist, it is not a single, એ ખાલી orthopedist નથી. That require comprehensive planning. I'm not going to detail. You know that physiotherapy, હા, alignment કેટલું જરૂરી છે, કેટલી index છે, then સાથે બેસી એનું planning કરવું જોઈએ. The reason is, suppose as a orthopedic surgeon, I will ask therapist, how can we help this child? I will ask to my prosthetist, how we can help this child. Then you have to plan accordingly. Then we and physiotherapy સાથે સાથે શું modifications કરીએ. Sometime this patient જ્યારે mid foot break થવા માંડે, then at the time sometimes it requires some foot surgeries, but needs a comprehensive approach. This child, it's a 10-year female child walking difficulty. વોકિંગ વિડીયો બતાવો, વેરી ઇન્ટરેસ્ટિંગ ચાઇલ્ડ. મારી પાસે આ શેની ટ્રીટમેન્ટ લેવા માટે આવેલું, ફૂટ ડિફોર્મિટી માટે. રિફર ફ્રોમ સુરત. સુરતથી રિફર થયેલું પેશન્ટ. મારે ત્યાં બીજા એક સર્જન પાસેથી આજે સવારમાં એની સર્જરીની ડેટ છે. ફૂટ છે એ બહુ બહાર છે, હું તમને વિડીયો બતાવું. હાઉ ઇટ વોઝ ઇન્ટરેસ્ટિંગ. સ્વરા એનું નામ છે. વેરી ક્યુટ ચાઇલ્ડ. How she walks. મેં તમને બાજુમાં કહી દીધું છે એટલે. So this is a known case of meningomylosis. શું કરશું આમાં? પેશન્ટ NBM હતું અને પેશન્ટ બીજેથી એડમિટ થવાનું હતું અને પેશન્ટ કેમ ફોર અ ફૂટ સ્ટેબિલાઇઝેશન સર્જરી. ડેફિનેટલી હું પણ આમાં ફૂટ સ્ટેબિલાઇઝેશન કરું. બટ વોટ યુ ઓબ્ઝર્વ, ધીસ ઇઝ a known case of meningomylosis. Yes, that is very interesting thing. ખાલી આપણે ફૂટ જોઈએ ને તો we will miss it. Have you seen the gait? There is a lurching. Fine. The next step, patient was ready કે સર અમને સુરતમાં તમારો સારો રેફરન્સ મળ્યો છે તો અમે રેડી છીએ ફૂટની સર્જરી કરવા માટે. તો મેં મારે પહેલા I want to see the what is the cause of શા માટે આ ફૂટ થયા. Then we will go for the X-ray. You can see for right side, have you observed what is this? Yes, there is a dislocated hip. So if I miss this one, so this is a disaster. If I treat the foot, there is nothing required for foot. Foot માટે કશું છે જ નહીં. There is a hypotonia. This is a known case of meningomylosis. તો પહેલી ટ્રીટમેન્ટ શેની જરૂર છે? PDA. So we did a surgery and show the video. How see? We performed the surgery no doubt. With stable, lurch is there because hypotonia, gluteal lurch weak છે, but with support. So such kind of cases, you require again a comprehensive approach. What is the cause of deformity? It is not like that. Flat foot છે એટલે therapy, icing, bracing, whatever. It is not like that. We have to identify the cause also. Case 5. Male 15-year child, deformity of both feet, pain after long walking. બે જ કેસ છે, ચિંતા ન કરશો. ખ્યાલ છે બગાસા મંડ્યા છે આમાં. Trying to get it. 5. Okay. So all having flat foot. મારી પાસે બતાવવા માટે એક જ પગ આવ્યું હતું. એક કામ કરો તો બધા બાજુ ઉભો હતો. હમણાં જ કેસ છે, ભુજનું પેશન્ટ છે, મારા આઉટરીચ ભુજ. એ બધાને ફ્લેટ ફૂટ છે. મેં એના પપ્પાને પૂછ્યું તમને કઈ પ્રોબ્લેમ થયો? સાહેબ મને ખબર જ નથી. ટ્રુ સ્ટોરી, મને ખબર જ નથી. મમ્મી તમે ઉભા રહો ત્યારે એ નહીં છે, મને કહેવાય તો તમારા છોકરાને શું ચિંતા કરો? કશું નહીં. આઈ થિંક હી ઇઝ એ ડીએમ છે આપણી મુન્દ્રા પોર્ટનો એનો, અને 47 યા 50 યર્સનો છે. 50 વર્ષમાં તમને કઈ પ્રોબ્લેમ હોય તમારા દીકરા કશું નથી થવાનું. ઇવન ધો બટ ધ કમ્પ્લેન ઇઝ લાઈક ધેટ. લોંગ વોકિંગ છે, હું ખૂબ ચાલું છું ને તો એને મને પેઇન થાય. That is called symptomatic flat foot. Again, Kaushal has told that symptomatic. What is symptomatic flat foot? કે ભાઈ હું અમુક ડગલાઓ ચાલી અને મને એને વાત કરી કે ભાઈ જે કૌશલ્ય વાત કરી, I have foot pain, knee pain, ankle pain, hip pain. That is called symptomatic flat foot. Symptomatic flat foot. You have to identify the symptomatic flat foot. Then definitely you can try rest, modification, icing, massage, needs your therapy, 15 therapy. આજે મેં ઘણી થેરાપી પહેલી વાર શીખી. Actually therapist અમે ભણ્યા ના હોય, અમે ખાલી એટલો જ વર્ડ ભણ્યા હોય, થેરાપી. ના, ધીસ ઇઝ વેરી કોમન. એટલે ઓર્થોપેડિક સર્જન છે ને, તો વી આર હાઈલી ઇગોઇસ્ટિક પર્સન. હોવું ન જોઈએ, પણ સર્જન્સ આર ઇગોઇસ્ટિક. ફિઝિયોથેરાપિસ્ટ ને એવું લાગે અને ખરેખર હોય જ છે એવું. બટ ધીસ ઇઝ વેરી કોમન. હું ઓર્થોની વાત કરું છું. આઈ એમ ટેકિંગ અબાઉટ ઓર્થો સર્જરી.
સર્જનમાં સાહેબ ઓર્થો સૌથી વધારે હોય.
રીઝન ઇઝ સામે તો I have a strong evidence for that. I have a strong
Your
evidence.
point of view, sir.
No, I have strong evidence for that. You know why? See, we the surgeons, તમે જનરલ સર્જન જુઓ ને સાહેબ, એ આંતરડા જોડે, આંતરડા સ્મૂથ મસાલા બનેલા હોય. We are orthopedic surgeons, અમારા બોન છે ને મજબૂત બનેલા. It's very common. Really egoistic person. અને એમાં લખે કે SWD. સાચું કહું, SWD ની ડેફિનેશન ન ખબર. It's very common. સાચે. અને કેનામાં અમે ખાલી આ લોકોને લખીએ કે થેરાપી ઇઝ નોટ માય પાર્ટ ને. જેમ તમે રેફરન્સ આપો તો તમે થોડો મને સજેસ્ટ કરવાના છે તમે કઈ સર્જરી કરો. ઇટ્સ વેરી કોમન. હા, એટલે હું આજે થેરાપી લખું તો ધીસ ઇઝ યોર જોબ. ભાઈ યુ હેવ ટુ, એમાં મારી એક્સપર્ટાઇઝ છે જ નહીં. હા, આટલી ખબર પડે કે ધે નીડ એ ફિઝિયોથેરાપિસ્ટ એક્સપર્ટાઇઝ. પછી એમાં મારો કોઈ રોલ નથી, મને ખબર જ ના હોય. આઈ શુડ નોટ ગાઈડ યુ. સો આમાં વી નીડ એ કોમ્પ્રિહેન્સિવ એપ્રોચ. આમાં આપણે એવું નહીં કોણ સાચું, ધેટ નીડ એ કે આમાં સો મોડિફિકેશનની જરૂર છે કે ફિઝિયોથેરાપીની જરૂર છે કે ઓર્થોપેડિકની સર્જરી જરૂર. ફાઇન. લાસ્ટ કેસ, ઇટ્સ વેરી ઇમ્પોર્ટન્ટ. 10 years male child, fit deformity but progressing in pain while walking. આ પેશન્ટને પાછળથી જોવાનું. જે મેં રાઉન્ડ કર્યો છે ને, આ સી ધીસ ઇઝ કોલ્ડ too many toes. બહુ બધી પાછળથી ટોસ દેખાય. હા, બહુ બધી ટો દેખાતી હોય ને તો there is something, કંઈક છે. કા એને કોઝ ગડબડ છે અથવા તો રિજિડ ફૂટમાં છે. આ પેશન્ટનું તમે એક્ઝામિનેશન કરો ને તો એની સબટેલર મુવમેન્ટ ના હોય. સબટેલર મુવમેન્ટ કેમ ચેક કરવી? સિમ્પલ જ તમને એક્ઝામ્પલ આપું. પેશન્ટને છે ને 90 ડિગ્રી રાખવાનું અને હીલને આ હલાવવાનું. આ જે મુવમેન્ટ ન હલે ને ક્લબ જે ફ્લેટ ફૂટમાં, ધેન યુ હેવ ટુ, બે જ ટેસ્ટ છે, ક્યારેય રિજિડ ફૂટ મિસ ન થાય. એક હીલ રાઇઝ ટેસ્ટ, આર્ચ ડેવલપ નથી થતી, એન્કલને 90 ડિગ્રી રાખો, કેલ્કરીને મૂવ કરો, કેન્કલીન મૂવ નથી થતું, ઇટ મીન્સ there is a no subtalar movement. Then you have to think about something else. This is not a flexible flat foot, this is a rigid foot. બરાબર? આ પેશન્ટને that we have, this is a rigid flat foot and we have done investigation that is called calcaneonavicular collision. અમારી પાસે બહુ બધા neglected આવે અને that's very easy to treat if we identify early. જો આ પેશન્ટને આપણે 17 વર્ષ સુધી જવા દઈએ, then it leads arthritis, subtalar arthritis, ankle arthritis, very common. એને વહેલા પકડી લઈએ, બહારને એક્સરસાઇઝ કરી દઈએ, ત્યાં ફૂટ મૂકી દઈએ. ઇટ્સ વેરી ગુડ સર્જરી, મિનિમલ ઇન્વેઝિવ સર્જરી છે. નાના ખાલી 5 સેન્ટીમીટર ઇન્ચમાં સર્જરી પૂરી થઈ ગઈ. ધીસ ઇઝ એ બાર. આ શું હોય ખબર છે? નેવિક્યુલર અને કેલ્કેનિયમ છે અને આ બે વચ્ચેનો બાર બની ગયો છે. આખો બાર હોય, that will not allow the free movement, subtalar movement થાય નહીં. We'll exercise it અને વચ્ચે ફેટ મૂકી દો, patient will absolutely fine. There is very minimal invasive surgery. So what I learned, this is my learning from you guys and from So for flexible flat feet, there is no concrete evidence that available treatment alter the natural course of foot shape and development. So observation is the best thing. Yes, for rigid foot that require investigations and treat according to the course. So ultimately, I conclude my talk. All flat feet are not same. There is something. First thing is